Okay, our last adventure lands us to the thyroids and the parathyroids, and I know you are glad this is the last adventure. So without further ado, let's get started. If you have any questions about anything, please let me know. I know this material, a lot of people think it's really confusing. I've tried to break it down as much as I can. Usually if you can get one disorder, you can get the other because they're opposite. But if something's just not sticking and you need some more one-on-one, feel free to get a hold of me and I will get with you and we'll see what we can do to help you understand it better. All right, thank you very much. Oops. All right, the thyroid and the parathyroid, fast fact sheets. You read chapter 46 in your Med-Surg and 981 through 986 in your Peds book. All right, I've broken this way down to the short and sweet version. There are 3 thyroid hormones, T3, T4, and calcitonin. T4 regulates metabolic rate, and it controls the rate of body cell growth and development. T3 regulates metabolic rate, controls the rate of body cell growth and development. Calcitonin helps ossification and bone development. Now what you need to remember is that T4 is a precursor of T3. You have to have T4 to convert it. About 10% of circulating T3 is secreted directly from the thyroid gland, and the remainder is obtained by peripheral conversion of T4 to T3. So you can see if you have a deficiency of T4, you're in trouble with T3. Iodine is necessary also for the synthesis of thyroid hormones. So in the presence of lacking iodine, T3 and T4 will be down. The best way I can tell you to remember the difference is think speed up or slow down. Hyperthyroidism, speeding up. Everything's speeding up. Okay, it should pop in your head. Excessive hormones, speed up. The causes, there are many, but the most common is what we call Graves' disease, which is an autoimmune disorder. The hallmark signs that you're going to see, is hyperthyroidism, which is an increase in T3 and T4, a goiter, and exophthalmos, which is abnormal protrusion of the eyes. And there's a good picture of that on page 1378 in your book. Okay. Manifestations, everything speeds up. So if you look on page 1378 in your book, chart 46-3, signs and symptoms, tachycardia, AFib, tremors, a goiter, warm moist skin, hyperreflexia, eye changes, hair loss, corneal erosion, hyperactivity, irritability. So on the test, if you're looking through there and it says check all that apply, signs and symptoms of hyperthyroidism, think speed up. Pick choices that have to do with things speeding up. Okay? Diagnostic finding is based upon appearance, increased T3 and T4 levels, decreased TSH. Also, thyroid scan, they're going to do a thyroid scan, and the RAIU is going to be increased. The radioactive iodine uptake will be increased because it's taking up more, because there's more of it around. There's too much. Okay. Medication precautions, they are going to be putting them on some medications. I'm getting there, sorry. As far as when to take it and how long to take it, a patient with hyperthyroidism will have an increased uptake of iodine that I talked about earlier, more than 35%. So what an RAIU does is it increases the activity, it measures the activity of the thyroid. It measures the activity of the thyroid, okay? Whereas the thyroid scan is a low-intensity radioactive iodine used in the scans, okay? So with the thyroid scan, the iodine has very short life and no radiation precautions. But with the radioactive iodine uptake test, there does have to be radioactive iodine precautions. Okay. And you want to do a very careful history of their medications, okay? Seeing what medications that they're on. Are there any medications that contain iodine, for example, medication precautions? If they are, those should be discontinued for about a week before a scan. So if they're on iodine medicines, they need to be discontinued for about a week before the scan. Okay? So we have the two main things we met. We measure the lab. We look at their appearance. Do they have those hallmark signs of the goiter and the exothalamus? Do they have a decreased TSH level? And if you think about it, remember TSH is with the stimulating hormone, and it's going to be decreased because there's so much of the T3 and T4 that is pushed way back, and it's not wanting to stimulate that thyroid to secrete any more T3 and T4. We talked about the thyroid scan, measures the position, the size and function of the thyroid gland, and then the RAI, radioactive iodine uptake test. Okay. This is, again, measures the activity of the thyroid. Okay. Management therapy to decrease the rate of hormone secretion and the prevention of complications. They're going to be given small, frequent meals that increase calories, proteins, and carbs in it. They need very quiet, non-stimulating environments. We want to bring everything down. They may end up with a total thyroidectomy or a radioactive iodine therapy to decrease those levels. Pharmacologically, they're going to be put on anti-thyroid drugs such as PTU or MTZ, and these inhibit thyroid hormone secretion. Also, they're going to be put on beta-adrenergic blocking agents as well to help with some of those signs and symptoms. If they are put on PTU or MTZ, we need to remember that these inhibit the synthesis of thyroid hormones. PTU also blocks the peripheral conversion of T4 to T3, which will decrease that level even more. With signs of infection, you want to stop the medication and see their healthcare provider. They need to watch for leukopenia. That's rare, but it does occur. So they would need to watch for infection, fever, for signs of leukopenia occurring. Don't use with decongestants, poorly tolerated. Don't use in late pregnancy, can cause goiters in the infant. And improvement should occur in 1 to 2 weeks, with good results within 4 to 8 weeks. The beta-adrenergic blocking agents, Inderal, is the drug of choice. It helps control the symptoms by the nervous system, such as the heat intolerance, the palpitations, and the nervousness. They will be also put on something called Lugose solution, which is given in large doses. It inhibits the synthesis of active thyroid hormones and reduces the risk of hemorrhage. So what it does is actually decreases the size and vascularity of the thyroid gland. We will give that prior to surgery because we want to decrease the size and vascularity of the thyroid gland prior to surgery to prevent any kind of thyroid storm. Radioactive iodine therapy is simple to administer. It's economical. It's prescribed on an outpatient basis. You want to watch for signs of hypothyroidism. Tasteless, colorless, single dose is given. It is eliminated in the urine, saliva, sweat, and feces, so you have to watch for that. 3 to 4 weeks, they should resolve in totally by 12. If it's surgical repair, a thyroidectomy, subtotal or total removal, you can live without 5/6 and function with only 1/6 of your thyroid. They're going to have a collar incision. Preoperatively, you want them on a high-calorie diet, but avoid stimulants, no tea, coffee, or anything like that. Teach them to support their neck postoperatively. Again, they're going to need to be put on medications prior to surgery, your anti-thyroid drugs, and your Lugose solution. Postoperatively, they need vital signs every 15 minutes until they're stable, and then every 30 for 12. Their neck is going to be flexed to avoid strain on the suture. You don't want them to have to reach for a lot of things. You want to make sure, for example, like their colite is within reach. They're going to be in semi-Fowlers with their head elevated and supported with pillows. They're going to need pain control, O2 and IV fluids. Check the dressing and reinforce it as needed. And monitor for damage of the laryngeal nerve, because that can occur. Diet of choice, no stimulants. Keep things within the patient's reach. Some major complications that can occur are things like hemorrhage, stridor, and hypokalemia, resulting in tetany and seizures. Alert, you want to make sure that you are monitoring them for what's called a thyroid storm. This is a medical emergency in which you will see three cardinal signs. Number 1, tachycardia greater than 130, fever greater than 100, and hypertension. You also may see irritability, restlessness, vomiting, and diarrhea. If left untreated, this is fatal because they go into dehydration, delirium, coma, and then death. Okay. Management of a thyroid storm. The immediate management is to decrease body temperature, decrease the heart rate, and prevent collapse. So you want to treat all those major signs and symptoms. Administer meds, the PTU, the MTZ, cardiac meds, sedatives, corticosteroids, and then we don't put them on aspirin because we don't want them to bleed because it's already highly vascular and they have a bleeding tendency anyways. IV, O2, and hypothermia blanket is needed to decrease the fever. Okay. For hypothyroidism, you've got type 1. The first type is congenital hypothyroidism, known as CH. This is a congenital deficiency of the thyroid hormone that leads to central nervous system impairment. It can be in the fetal or neonatal life, and if not treated, results in mental retardation. The cause is the embryonic failure of the thyroid gland to develop. Warning signs would be remarks about an unusually quiet and good baby with signs and symptoms of hypothyroidism. So this baby is the best baby. It just sleeps and sleeps and sleeps and never gives me any trouble, and I don't hear anything from it, and along with signs or symptoms of hypothyroidism. So think about things slowing down. Management is lifelong thyroid hormone replacement therapy, either Synthroid or levothyroid. It's tasteless and it's mixed and crushed and added to formula, milk, and food. So testing on all babies to ensure adequate thyroid function has come about. If diagnosed early, complications can be prevented. T4 screening if low, followed by TSH, and that would be high. Okay. All right, hypothyroidism in the adult years results in what's called myxedema. Think slow down. This results in edema that causes facial tissues to swell and look puffy but non-pitting. The main causes is thyroid surgery and radioactive iodine treatment, killing too much of the thyroid. Manifestations are on page 1371 in your book. Now you need to think of everything slowing down. Okay, dry skin, bruising and wound healing, cold extremities, hair loss, bradycardia, peripheral edema, tiredness, weakness, cold intolerance, constipation. Okay. Features, the red flag is extreme fatigue. So if you have things on your test that says pick the signs and symptoms of hypothyroidism, think slow down. Anything that slows down. Okay, extreme fatigue. Diagnostic would be just the opposite of hyper. You'd have decreased T3 and T4 levels. TSH depends upon if it's a primary or secondary problem. And RAIU this time would be decreased instead of increased. Management is lifelong hormone replacement therapy with like Synthroid. The main side effects, you want to watch for hyperthyroidism that can result. Nursing considerations, you want to monitor vital signs. Application of a heat is no-no. They are very sensitive to narcotics, so you have to be very, very careful. They can have weight gain as well, so you have to watch them for weight gain. Rest periods, instructional medications, avoid constipation, cold intolerance, and monitoring for infection. Okay? So as long as they take their medicines, they usually do fine as long as they stay on that for life. Thyroiditis, they have acute, subacute, and chronic. Just know that there's 3 types. Acute usually is a bacterial infection of the thyroid gland. Subacute is usually a viral infection of the thyroid gland. And then chronic is usually what's called Hashimoto's disease. which is triggered by viral or bacterial invasion of the thyroid gland and results in autoimmunity, leading to thyroid tissue destruction and low hormone levels. Okay, parathyroid glands, hypo and hyper, are the parathyroid glands. Do you remember where these are located? They are attached to the posterior surface of the thyroid, one superior, one inferior on each lobe, so therefore there are 4 of them. What do? They produce parathyroid hormone, PTH, and PTH, along with vitamin D, helps maintain homeostasis of calcium levels, so very important for calcium concentration. The effects of PTH, well, an increase in PTH will result in an increase in calcium and a decrease in phosphate. There's an inversal relationship between calcium and phosphate. One goes up, one goes down. A decrease in PTH, which is your parathyroid hormone, results in a decrease in calcium levels and an increase in phosphate levels. So you need to remember those. Hypoparathyroidism then results in a condition, because we have decrease in calcium, tetany. This would be muscle twitching, spasms, and convulsions, and the main cause is accidental damage to the parathyroid during thyroid surgery. Hyperparathyroidism results in demineralization of the bone, and if not treated, bones will become deformed and easily fractured, and the main cause of hyper is tumors. Okay? Hyperparathyroidism is an overproduction of PTH, which results in increased calcium levels and bone demineralization. Diagnostic, they're going to do x-rays. You're going to see increased calcium levels with decreased phosphate levels and increased PTH levels. Manifestations, you're going to see things like anorexia, nausea, vomiting, constipation, pain, confusion. They need lift sheets, not left sheets, lift sheets to avoid pathological fractures. Management depends upon the cause. Hydration with normal saline, diuretics, medications. If it's a tumor, removal of it, and restore calcium balance. Preoperatively, you want to increase their fluids, cranberry juice to decrease urinary pH, strain their urine, do not use thiazide diuretics. High foods and calcium are limited. And postoperatively, watch for signs of tetany. You always want to have calcium gluconate at the bedside following surgery, and you want to watch for signs of respiratory distress related to hemorrhage and laryngeal nerve damage. Hypoparathyroidism is an underproduction of PTH, and it can be Beta-Adrenergic or idiopathic. In other words, we don't know what causes it or we induce it. The 2 names of the signs used to test for tetany and how each one is manifested for. You do need to look those up and remember those. One is called Trousseau sign. And if you remember, Trousseau sign was when you have a spasm caused by a flexion of the wrist when you apply a blood pressure cuff for at least 3 minutes. So you put the blood pressure cuff on, and you allow for about 3 minutes, and if you have a spasm of the wrist pointing and coming upward, then that's a positive Trousseau sign. Chbosky sign was when you have a facial muscle spasm that you can attempt to elicit by lightly tapping on the patient's facial nerve adjacent to the ear. So you will tap on the facial nerve adjacent to the ear, and you will have a facial spasm that will occur, and that's considered positive for tetany, those 2 signs. Trousseau sign and Chbosky sign. Manifestations, you're going to see anxiety, numbness, tingling, cramps, depression, confusion, and delirium. Decreased calcium levels, increased phosphate levels, and decreased PTH, just the opposite of what we talked about earlier. Management is increasing your calcium levels and decreasing your phosphate levels. Again, calcium gluconate, vitamin D, diuretics, and decreased stimuli. You want to recognize this early for signs of hypocalcemia and get that replaced. Decreased stimuli. Diet would be increased calcium and decreased phosphate. And that's what it's all about. That one's not as hard, so there should be easy to remember those. All right, that's it. So if you have any questions or concerns about anything that I talked about, please feel free to let me know, and I'll get with you as soon as I can. Thank you.